we are talking about the new wave of stroke rehabilitation with assured results.
We are harnessing the person's potential. We are doing everything to get you back to how you were before the condition. And that is the beautiful thing about that. And it's possible. It has happened with a number of cases that we've seen.
Hello everybody, welcome to another interesting episode of the Physytek podcast. Today we have someone that I consider interesting because he's a man that wears many hats in my life and in his profession as well. He's somebody that I have a personal relationship with, so I kind of know what I'm talking about when I say certain things. And we are talking about the new wave of stroke rehabilitation with assured results. It's quite interesting because stroke is a really broad topic, and it is something that can take us a whole lot of time to talk about, but we will try and bring together the salient points that will benefit you, therapists, patients, family members, or just an individual who wants to be educated on stroke. So we promise that this episode is going to be for the understanding of everybody, so you don't need to be a technical person to watch this episode. I hope you're ready to delve in. So let me introduce my guest. He has about a decade of experience in physiotherapy. He is currently a principal physiotherapist and is the head of department of Greater Accra Regional Hospital that we all call Reach Hospital. He is the CEO of NERA. NERA is New Ridge Rehabilitation Agency. It is an agency that gives physiotherapists to patients in need of physiotherapy services. He is also the executive director of Daystar Health Center. He has an MPH in Global Health Program. He is currently studying another MPH. I said he's an interesting man. Another MPH in Epidemiology and Disease Control. He is a certified Bobath therapist. And like I said, he wears many hats and he's very knowledgeable, interesting, and fun. He is in the person of my very own friend, brother, boss, Mr. Brentin. Welcome, very.
Thank you. Thank you for having me.
All right, so I just want you to give us a brief intro or something about how you got into stroke rehabilitation, the history. Did something happen or you just woke up one day and found the interest in stroke rehab?
All right, thank you so much. I want to use this opportunity to thank you for inviting me here, and I want to commend you for the good work you are doing and the knowledge you are passing across to your viewers.
Thank you.
I think as a physical therapist or a physiotherapist, once you are in school, you get to get exposed to a number of conditions. So I personally decided to go for a condition that I can make significant impacts in the life of the patient. So we have cases like low back pain. So someone can actually walk in with low back pain. Sometimes you don't really see the disability unless it's something very severe. And when you help the patient is the one that can appreciate it. However, when you have a case like a spinal cord injury, Parkinson's disease, or stroke, it's slightly different. The family is seeing the disability or the impairment. Yeah. And when you're able to make a big difference, the patient can't walk at all, you can get the patient to walk again. I think that's something that brings me a lot of satisfaction. And that's what made me have that interest in, especially with stroke. We have other professions that play a role, but physiotherapy plays a very vital role that cannot be ignored, and that's why.
So you're saying you have other interests like Parkinson's, spinal cord injury, so you're not only focused on stroke?
Yeah, I'm mainly focused on neurorehabilitation. So any neurological condition.
So There has been quite a number of treatment approaches that we as Ghanaians know. We can talk of the herbal medicine. We can talk of the one we popularly call atamami. You go, if you have stroke, they will rub some ointment on you, massage you. Some people like shake you and things, and then we have physiotherapy. And I understand some people even seek chiropractic for
For
stroke.
really?
Yes,
I
yes.
see.
These are things
That's
that
new.
So, what do you think about these various treatment approaches?
I think when it comes to medicine, we've moved from the era of focusing on expert opinion. Now we are doing a lot of research. We are looking at and even the research, you can't just take a maybe a cross-sectional study or someone did a case control study. It should be something that the evidence is quite high. So we look at maybe meta-analysis, systematic reviews, or maybe a randomized control trials. So you don't just look at a particular treatment and say, oh, this person said, I did this and this for the person, and this is the result that we had. So that's just an expert opinion, and he's an expert who qualifies the experts. You understand? So it's not about what people say, it's what the evidence show.
Okay.
That's what we look at, and the evidence should be sufficient evidence.
Okay.
So when it comes to in Ghana here, we have various treatment that people use. Even in physical therapy, we have different treatment approaches that we use. Some are good, some are not good at all, and some are that bad. So
That's bad.
yeah, it's rather causes harm than good.
So okay, so
So
by
this
that bad you mean they have various implications on the health?
yes. For instance, there are certain approaches or treatments that can be done and will cause another problem. So one of the problems we have in stroke is that hemiplegic shoulder pain, and mostly it's not caused by the condition.
Can you break the hemiplegic?
Okay, so for instance, when someone has stroke, one side is paralyzed. So when that side that is paralyzed, the particular shoulder start having a pain with unknown origin, you're not sure what actually caused it. The patient was doing well, all of a sudden started feeling pain in the shoulder. So that's what we call hemiplegic shoulder pain. There are other names for it. Like we can also call the complex regional pain syndrome, which is more complex, like the name suggests.
Yes,
So
yes.
we go for the hemiplegic shoulder syndrome. Or yeah. So with hemiplegic shoulder pain, so with that, it is not the condition that actually brings it. It is the handling.
Okay.
It is the manipulations that are done for the patient. So, for instance, someone goes and they are applying some herbs on it and moving the shoulder. I think as we go along, I'll explain it to detail. So, let me answer your question. So, with the herbal and the other treatment approaches that are used in Ghana here, the evidence suggests that the physical therapy is the best treatment option for stroke management. And the reason is that when someone has stroke, even though it is a cerebrovascular disease, but it's coming from the brain, it is not a musculoskeletal problem. So we are not looking at mostly they look at the muscle is weak. So what can I do to make the muscle strong? What can I do to let this person walk again? Forgetting that a whole lot, quite complex activities go on to make this hand really function. They forget that. So when you go and see someone that's a herbalist, like as you mentioned, they apply something. They are looking at this hand is not working.
How do I get it to
How
work?
do I get it to work? So they start applying whatever they have to apply and all that because they forget or they don't know. Yes, they don't know what actually is going on. Some actually think the problem is coming from the hand or the lower limb. That's what they think.
Yeah.
So there's not much evidence. However, we need to understand that when someone has stroke, it's different from if you have stroke. Stroke actually akin to the phrase heart attack. Heart attack, when it happens in Ghana, when you have a heart attack, what happens to you?
You collapse.
Then
Then you become.
you die. That's what happened. Mostly
Okay,
in Ghana here,
ultimately, yeah.
most people that have heart attack, we don't have the systems in place to prevent the death. Mostly it leads to death. The same thing with stroke. So when you have stroke, most likely you're going to die. So stroke actually is a brain attack. So when it happens, the person naturally will die. So those that survive are the ones we treat. They're actually stroke survivors. So those are the ones we treat, they survive. So you can't say that, for instance, let me use like breast cancer.
Okay.
So breast cancer, we have breast cancer patients. It's different from a breast cancer survivor.
Okay.
There are different terminologies in documentation and all that. So it's the stroke patient that we are treating is a survivor. He survived the stroke. You understand? So it happened in the brain and it comes with its implications. And that is what in physiotherapy we focus on, that system. So there's a big word, I don't know how to break it down, neuroplasticity. So we are trying to reorganize the brain cells, ensuring that the right connections are done so that the person can function again. So that's what we do. And that's why when a person has the condition, the first thing that is done is to allow the brain cells to have the oxygenation that it is lost. I don't know if you get that. Yes. So that is where herbal sometimes plays a role. Sometimes they give medications in that state of the stroke, not after the survivor. So herbal medicine is not effective in any way in the rehabilitation itself.
Okay.
But the medications that it gave, though studies have not gone into it to say that it helps with the reperfusion of the brain. That's allowing oxygenation. But some medication they give for certain people in that case, especially in mild cases, it helps to some extent. So if we want to use that, then we need to do more studies in that. Okay. I don't know if you get to do more studies in that. So we can't, there's not sufficient evidence to even support that. However, it works in certain instances.
So why do you think that it works in certain instances? Because there are patients that come like, oh, I had stroke and then I went to this herbalist and they gave me this medication. And then I said, like, I'm okay. I do everything that I was doing before, or almost everything that I used to do. How do you explain that?
Yeah, I think that there's a difference between transient ischemic attack and a stroke itself. So some people, when you have a transient ischemic attack, it's temporal. So somebody can have that even by not giving the person any medication or water and improving ventilation and all that, and doing something that can stabilize the person. In a space of 24 hours, the person will be okay. Then even in stroke, there's something we call spontaneous recovery. The brain has a way of recovering by itself. So we can't attribute the medication to the recovery. Sometimes it can be from the brain itself. That happens. Then, like I said, we haven't really studied the phenomenon to see that, okay, the reason why the person got better is because of the drug or is because of spontaneous recovery. We can't tell. But I've been practicing for a while and I've seen patients that they come in, you give them an appointment, they go and do some herbal and they come back, they're okay. But most of them, when they come and you assess them very well, you find a lot of deficits. However, you are able to, maybe there's some function the person can walk. But what is walking? We are in physiotherapy, we are not interested in walking. We are interested in the quality of the work. Yeah. You see, that's where the issue is.
So over here, when somebody is disabled and for any reason, maybe herbal treatment or any other alternative, the person gets even a little form of improvement, we see that an achievement, because they will be like, oh, I was not even walking at all. You know, I
Yeah.
was bedridden, but now I can, at least I can move my hand. At least I can take some steps. So what do you think we need to do to let people know that they can actually do better than just moving their hand and just moving their leg? You know, we accept the little changes that we get as recovery, and then we just close the case, because
Yeah.
I mean, I mean, the recovery process is actually quite long. So if we get something small in the few weeks, we think that, I mean, in just 2 weeks, just 3 weeks, I can move my hand, I can move my leg, let me maintain it like that. So that's something we can do about it.
I think this is an excellent question because, as you rightly said, most people have the notion that once I have this problem or stroke, it goes with a disability.
Yeah.
And if I'm able to get something small,
Small.
then it is fine. And unfortunately, clinicians also tend to think in that light to some extent. But one thing I want to say here is that the stroke patient is capable of much more than we are called to them.
How capable is this
Yeah, so
patient?
when someone has a stroke, a lot happens. In the according to some data that I looked at, when you have the stroke, it doesn't take a lot of time for the brain cells to die. So just 1 second, and this will surprise you. 1 second, you can lose 32,000 cells, brain cells,
Wow.
in 1 second. So imagine in a minute.
Minutes.
So that's why we always say be fast. Once you see the signs, you have to go in for reperfusion to be done. And that's what the physicians will do on the ward, ensuring that the brain cells are getting oxygen, enough oxygen, oxygenated blood. So that is very important. So the recovery actually depends on how long we stayed away from that kind of treatment.
Okay.
You see, so the more the person stayed at home, the more brain cells will die.
Right.
However, irrespective of the number of tissue death or the extent of tissue death, we can get a full recovery for most people.
100% recovery.
You can get, I can't say 100%, but it depends on the type of stroke and how fast it was.
Okay.
But I've seen stroke patients that we have seen that using the concept that we use or I use, you can get a patient walking and you wouldn't know that the person had a stroke. So that's what we look at. So you can get a person to a near full recovery, and that is a possibility. And it's just knowing the right thing and doing it. Yeah.
So in your talking, you mentioned that the moment they see the signs, what are the signs that a layman, an average man would see that, oh, when this is happening, I might be having a stroke and I need to get help immediately?
Okay. So there's something that we use, we call it the FAST. FAST.
Okay.
So that means we are just telling you be fast.
Okay.
But that FAST is an acronym, and the F means face. So the face, you are looking at your face, the symmetry of the face, like the face, one side seems to be dropping, and you see that you the person that is observing the patient or whoever it is, you see that the facial alignment is not good. Then the next thing is the A, so the arm. So you feel some numbness. That gives you the sign, the numbness or some form of weakness in the arm. Then we have the S for speech. So you see that the person is talking, but the speech is slurry. He's talking, he's not talking well, and sometimes it's incoherent. So once you see these signs, then you go to the last step, which is the T. It's time to go to the hospital.
Okay.
Yeah.
That's an interesting acronym.
Yeah.
That's a very
So those are the things that you look out for.
Okay. So are there instances where a person will not see any of these signs, but would maybe black out all of a sudden and wake up with these things?
That's also a possibility
Okay,
when
so
the patient is at risk.
when the patient is at, so
Yeah.
what will put somebody at risk for such situations to happen?
Okay. So when we talk about stroke prevention, I don't know if I should go into this direction. It's a little lengthy. So
Something
as
brief.
yeah, so we talk about prevention. There are a lot of things. See, we have risk factors. Then some are modifiable, which means you can do something about them. There are some too. There's nothing you can do. I mean, like age. If you are old, you're at risk. If you are young, even though that is changing, there are a lot of things that are changing. We are in a health transition. And things are changing. The demographics are changing. Now we have younger people that are getting stroke, but age has always been a risk factor. Yeah. So there are two processes that occur in stroke before someone gets stroke. So we have vessel occlusion, which means and that is like 80% of all stroke. So that's what leads to what we call the ischemic stroke. So the blood vessel becomes occluded and there's no enough blood going through that. Then we have the intracerebral bleeding, which leads to hemorrhagic stroke. So these are so once you are at risk, your lipid, you have hyperlipidemia, you have hypertension, diabetes, you will start getting the signs little by little, like what we are talking about. Some people actually get it in a moment, but they ignore it. Then that's when it happens suddenly. So that also happens. But even when that happens, you start seeing some of the signs. Sometimes a month before it can happen, just a short time. Like ischemic, transient ischemic attack can happen within 5 minutes.
Okay.
Yeah.
Alright, so before we move on to our next question, we have a sponsor. Hooray. So we have a brand. It's called Starbound. It is a health brand that has wide variety of products, mainly for pain relief. So they have this one called Roll On. It is to massage the soreness on your muscles when you have any injury. Maybe you played football, you encountered any physical impact that caused some sore or pain. We have this one. It's a roll on, you massage it on your muscles and it relieves pain. And then there is a Starbound cold spray. I'm sure most of us are conversant with the cold spray. Just spray it on in your joints, your muscles, anywhere you are feeling the pain, and then it helps to relieve this pain. And then the last one is the warm gel. So this warm gel is more or less like the cold spray. Just that this is a spray, and then this is a gel, and then this is warm, and this is cold. But I believe there is a warm spray as well, and then a cold gel as well. So all these are wide range of products that helps with pain relief, muscle soreness that you can purchase for you. So it's called Starbound, Star and then Bound. Don't get the name twisted. So if you see it on the market anywhere, be assured that it is a trusted product that Physytek has endorsed. Alright, so can we talk about Bobath concept? Can you tell us what it is about and expose the public to what Bobath is all about? Because I know you're a certified Bobath therapist.
Yes, with the Bobath concepts, it's a lot.
Yes.
I'm just thinking of what I can communicate for.
A minute. So, by the way, we are going to have a workshop, right?
Yeah,
a series on Bobath.
Yeah.
So, we'll be expecting it on our channel very, very soon. We'll communicate with you, and we'll have an in-depth training on Bobath. So, be on standby for that workshop. So, can you continue?
Okay. So the Bobath concept is an old concept. It's been there for a very long time. So for people that probably graduated from school before I did, when they hear of Bobath, they remember the old Bobath. But the world is changing. Bobath too is evolving. So it's not the same thing. So it's been modified by contemporary neuroscience and rehabilitation. So it's not the same old thing. There are things that the person that brought the Bobath, which is Beta Bobath, actually put across that by other studies, further studies that recently have gone into that same Bobath concept has actually taking out some things.
Okay.
So the association has taken out certain things. Initially, she started it with adults, then had more interest in children, so children with neurological conditions. Then later on, new people that came on board took it a step further. It's not like our part of the world when people get knowledge, they keep it to themselves. You need to lay the foundation, other people to build on. So that's what the Bobath concept it does. And I should say that the Bobath concept is not a technique. Sometimes people say Bobath technique.
Yeah,
It's not a technique.
Okay.
And that's one thing I like about it, because it gives me an understanding that this is how it should be done. This is the way it should. But it doesn't tell me how I should do it per se, even though there are certain techniques in it, but it gives you the concept. So I know that before a person can be able to walk, there should be in a significant amount of postural tone. The tone has to be good. We have an understanding that the sensory system, for it to have a precise motor activity, it should be there should be a collaboration between the sensory system and the motor system. So having that understanding, it makes me know that, okay, if I'm going to see a patient and a person has impaired sensation, what business do I have working on the muscles whilst the sensation is poor? No, that is the foundation. I can't get a patient to do, sometimes we do weight bearing. The patients, we just start weight bearing, put the patient on standing, and you are trying to get some strength in the leg. But have you worked on the sensory system? If you haven't done that, you're wasting time. So it's a concept. So when I have that understanding, I know what to do. And because it's just a concept, it's not giving me technique, I'm at liberty to choose certain techniques from something like maybe the brainstorm approach, the root approach, or even the PNF. You get it? You can bring a little of what you learn from those areas into that. But the concept is comprehensive enough to get you the results without necessarily taking things from there, but you have certain knowledge from your traditional physiotherapy approach which you learn from school. I get it. So that's what basically what I should say.
Okay.
So then let me just mention the main thing that we focus on in the Bobath. So the first thing is that for a person to be able to walk, the posture has to be good. There should be postural control. That's what we look out for. And the sensory system, you need to work on the sensory system. For instance, in the sensory system, in our skin, we have skin receptors. In the muscle, we have proprioceptors. The joint and the muscle, we have proprioceptors. They are also receptors. So in the skin, so a lot of time people ask, if you have a patient, the patient is bedridden, he can't do anything at all. What do you have? What can you do?
Yeah.
So what they usually do is they go and just do mobilization and just move, which there are issues. Maybe another time we talk about that. So for the skin receptors, so you've heard about the Merkel disc, which is in the skin. It responds to touch. Then we have the Meissner's corpuscles, also responds to touch. We have the Pacinian corpuscles, that responds to pressure. Then we have the free nerve endings, pain, heat, and cold. So it responds to these things. So when the patient is there, all these things are impaired, they are not functioning. So just touch, that constant touch on the skin, you are activating these receptors. And when they are activated, what do? They send signal to the brain. And that is where the problem is. So that communication between the higher centers, which is the brain, and those receptors or the muscle itself is disrupted in someone that has stroke. So we need to restore that. We need to do proper sensory training or reintegration before you think of your muscle strengthening and all that. That is actually a latter part of the study. So the sensory system is something we work on with the Bobath. Then we also focus on selective motor control. So if I have a patient and the patient, I say do maybe shoulder flexion, and the person has to abduct, before the person can do. That is not selective. Selective means if I pick a particular muscle or muscle group, they should do the activity without others coming in. You see, so we want to avoid pathological mass patterns. That's what the Bobath focuses on, and we try to limit compensation. So I think I will leave it.
You leave it here. Okay, I think that is actually more detailed than the brief that I was expecting. So I think if you want more details, you subscribe to the channel and make sure that you turn on the notification button to be notified when we start uploading the series on Bobath. So let's go back to the stroke, since that is our main. Family members, relatives, and caregivers play an essential role in the recovery of stroke patients. What is it that causes stroke survivors? Sorry, stroke survivors. So, there are so many instances where family members expect that their stroke survivor relatives will be able to do certain things immediately. I mean, you have like, oh, miss, I said you should raise up your hand. You cannot raise it. It's just that they do not understand what is happening. That's why they are treating them the way they are treating them, or they just are in a hurry for recovery. What can we do to help these family members understand the processes that is going on, so that they will be able to have patience for the stroke survivors?
Okay, that's a very important question. So the family members play a key role in the stroke rehab process. However, I don't think that they are to blame in most of the behaviors that they put across. Like you said, sometimes is it that they are in a hurry? I think if you are paying, stroke rehab at home is not cheap. Yeah, so you want a patient to get well early. That's part. But it's all about the communication or education that the clinicians give to them. So sometimes you are called to see a patient, you just get there and start seeing the patient. You need to explain the procedure, the psychology behind it, why they will, you see, expected behaviors. You have to let them know that. So when that is explained to them, that understanding is the foundation for that understanding is laid. And it becomes easier for them to comply to the things that you tell them. It's all about the confidence with which you say it. And if you're able to explain it to them, I think, because for instance, this hemiplegic pain, shoulder pain we're talking about, a lot of it is caused by the family members and how they handle it. But if you don't take them through how they should do it and tell them what is expected of them, sometimes it becomes a problem. But the stroke, of course, it takes some time, and all stroke is not the same, you see. So it depends on the type. For instance, the brain cells, there are some that are highly susceptible to ischemia. Some are resistant. So it depends on the area that is affected and how the implications on the patients. So when we have that understanding that it's not the same, sometimes I personally have go to a patient's house and they'll be like, this one, his own took like 2 months.
Why is this one taking so
took long and all that. I think because they don't understand. Per what I know, hemorrhagic stroke, the recovery is faster than ischemic, because ischemic sometimes it started a long time ago, but hemorrhagic is often instant. So the recovery, the tissue death is less, and you can't get hemorrhagic and stay at home. You will not be comfortable. But you can get ischemic stroke and be taking your small herbs, and you'll be managing at home and all that. So that's the issue.
Okay. So aside the hemiplegic shoulder pain, what other complications arise from stroke that are preventable?
Okay. So the hemiplegic shoulder pain usually will lead to what we call the shoulder hand syndrome, so the wrist as well. And subluxation, it can be prevented if the right things are done.
Like handling.
Yeah, like handling, mobilization. So usually when we go to see a patient, we start with for the shoulder. So the clinician start doing a full range of motion. You do not do full range of motion for shoulder if you don't know the integrity of the scapula. So if anytime you move your shoulder to 90 degrees, the scapula takes 30 degrees. So the scapula has to glide 30 degrees, and the glenohumeral joint will also move 60 degrees to make 30 plus 60, 90. You get it? So imagine that if I am moving a patient's hand towards 180 and I'm going and the scapula cannot glide. So then I'm stretching it, but patient might not even feel it. But you are creating tension there. And that causes a pressure to come on the supraspinatus muscle, which usually leads to a tear or a tendinopathy. And that's what actually causes the pain. So if we give attention to what we call scapular setting, where you do a mobilization of the scapula before you even attempt the shoulder movement, that can be prevented. Another thing that can be prevented is the genu recurvatum. That's the hyperextension of the knee. So I don't know if I don't think I have time for a story. I would have told you a quick story on when I was doing my service. Yeah. So I was there. I'm not telling the story. I just say something briefly. I was there and I realized all the patients, most of the CVA patients, had hyperextension of the knee, and that is because they are blessed with a paro bar and a wall bar. We don't have some. So they are blessed with that. And when they put a patient on, they put a lot of, they're trying to let the patient put weight on the leg. But most often, we ignore the hamstrings, we ignore the glutes. And all that we are doing is pass bench, remove. And with this shoulder problem, pulling the scapula by force. You must go.
You will work today.
Yeah. Then you now put the patient, and as you are doing that, you are stretching the ligament at the popliteal fossa. With time, it becomes laxed, or loose. And when that happens, with insufficient strength in the hamstring, the person starts giving way, the knee starts coming backwards, and it starts walking like that. It's not something that happens with stroke. It's something that happened because of what you did. You see, so those are some of the things it can be prevented if we know. For instance, in Bobath, there's something that we talk about when we are talking about the postural control. The diaphragm plays a role in posture. So that patient that you went and the patient can't do anything, just deep breathing exercises, working on the diaphragm prepares the person for postural control. But you see, we don't know these things.
You see, it's also interesting because when, let's say, a caregiver or a family requests the services of a physiotherapist for their stroke survivor, they are expecting a peculiar treatment. They expect that the moment you come, you give them, some dumbbells so that they'll be raising some heavy stuffs, running, walking, some tough exercises, because they believe that it is these strength involving exercises that will help them to get back. So I think that is what most clinicians also, they adhere to what they
you don't let the patient, the family is not the one deciding. That means you are not a professional. Yeah, because the family should not decide for you how you treat the patient. It's all about explanation. So I get a patient, for instance, sometimes they'll say, oh, when the patient can walk a little, I don't let my patient start walking because you can walk. Because that walking is going to lead to the hyperextension of the knee. Because if the muscle strength in the hamstring is not good enough, the glutes is not good enough, you don't. So even though I know you can walk, and when I'm treating patients, mostly, you won't use Zimmer frame, but we will move you from the wheelchair, you can start walking. So the Zimmer frame becomes a thing of convenience, like maybe it has to be used because he's going to the washroom and all those things. But it's not a part of the therapy. We don't do walking using the Zimmer frame as part of the treatment. No. Neither will you use a paro bar. You don't need it because we don't walk around carrying paro bar. So we want to train you. We are harnessing the person's potential. So we are doing everything to get you back to how you were before the condition. And that is the beautiful thing about that. And it's possible. It has happened with a number of cases that we've seen. And sometimes you see the patient, you wonder if the person actually has stroke. Sure. I mean, for instance, a patient that I saw, which you know, usually getting the hand function is very difficult. So the person is totally paralyzed. Lower limbs, nothing on the hemi side. Upper limb, nothing. Just flickers, something small. In a month and a half, the patient starts typing. Because, you see, the patient is an administrator, and that means the patient has the synapses set up for fine motor activity. So why don't we pick that skill and get it back? Because it is there. You see, so we look at all those things, the history of the person. For instance, if you start learning how to play the keyboard, is a neuroplasticity. Neuroplasticity doesn't only occur because you have stroke or some condition. It's something that happens with us. Once you are learning a new skill, it's neuroplasticity. Okay. So that means anyone is capable of learning something new. Then you are capable of neuroplasticity.
That is a beautiful concept. So if you are watching this, you have to, if you don't pick anything from this, at least pick up the fact that you can recover from stroke and be almost the way you used to be. You do not have to walk in a certain kind of way. You do not have to accept that, at least I can move my hand or I can move my leg, so I am okay. There is much more to stroke recovery than just being able to do little taxes because you were not able to do it because of the condition that happened to you. So I'm rounding up, so two more questions.
Okay.
What are some specific treatments or things that we do as clinicians that you would want us to take out in order to benefit our patients who have survived stroke?
Okay. I think the first thing I would say is that what we want to do with the workshop that we want to do, because I try to bring people from Europe to come down to do a training in the Bobath. So we're trying to work with GPA. It didn't go as planned. I don't want to go there. So
that's story for another time.
Yeah, so we are trying to do something on our own, which won't be anything that will cost anyone other than maybe myself. So we are trying to work on that. So when it comes to, I want to say that we shouldn't think that what we know and what we have known all this while is enough. It is not. There are things you don't know. And that is why you are not confident in the profession that you are in. Because if you know and you are, I don't waste time trying to negotiate price with a patient.
Because you know what
I know what I'm about to do, and I know what the result I can get for you. So it's not my loss, it's your loss anyway. So that's the perception I have, because not many can do these things. And it's very important that maybe as clinicians we try to, even this concept is kind of I want to say something because it's something that might come in people's mind. The Bobath concept, per recent research, it is not something we are not saying that is superior to other therapies, but I can say for a fact it's superior to what we practice in Ghana. You understand? It's not superior to the PNF, but we don't know the PNF. Most people don't know the PNF. You only know the patterns. You don't know. There are a lot of things in the PNF, but we don't practice the PNF because there are a lot of technicalities and it's based on techniques. But with the concept, the Bobath concept, we are giving you an understanding. You see that? So once you get an understanding, you can apply the basic things you know and be able to help the patient. One of the things is that in our treatments, the pelvis plays a very vital role in extremity functions. I mean, if the postural stability from the trunk to the including the pelvis is not functioning well, then you can't get the extremities to function. If the scapula is not set well, so sometimes we get a patient, we perfect the trunk, then you see that all of a sudden, without doing anything for the hand starts moving, just because we have set it up for it to start functioning. So pelvic mobilization is important in stroke. Abdominal muscle strengthening is important in stroke. Scapular mobilization is important. It's not just strengthening dumbbell, you do squats, then you just walk and use the power bar by force. Whether you like it or not, you must walk today.
Yes. You have to walk.
So those are big issues that I am particularly concerned, because sometimes it's really I don't want to say annoying, but it's sad that you'll be there and a patient comes and say, oh, I did physio for 3 months or 4 months here, and you just analyze this patient, nothing looks like. And a lot of the spasticity that we see, one thing that I think we should take from here also is elbow mobilization. It creates spasticity in the arm. So once you are doing, you see, every stretch that you give, every movement you make activates a muscle spindle, it activates the GTO, and it also activates the skin receptors. When that activation is rapid and frequent, it causes hyperexcitability in the brain. And that response is what leads to spasticity. You see, and excessive pressure or excessive, I don't want to use fatigue, but when the muscles are fatigued, too much muscle strengthening, it leads to spasticity.
For the layman who doesn't know what spasticity is, can you please explain?
Spasticity. Okay, so you see, when sometimes a person is trying to move, but let's say the elbow, if you have elbow spasticity, it becomes stiff this way, you can't extend it, but the joint itself doesn't have a problem, but it's the muscle. So the muscle becomes tight, and you can stretch it. The moment you leave it, it's coming back. Okay, I don't think you have time for another story. Yes.
So
that's it. Yeah, that's spasticity.
And I think it's very common. Like, it's one of the most common things we see in stroke survivors, even those that have similarly undergone physiotherapy. They'll be like, oh, I have gone to physiotherapy. I have not started. I have recovered from stroke, but then you see that their hand is this way, and then they are walking.
And some of them too, as they are walking, always their hand is like this.
Yes.
Some may not be spastic, but as it's moving, all of a sudden the hand moves this way, and there's some space here. This is closer to the body from the scapula. Because you don't do scapular mobilization, it's not gliding effectively.
This is interesting. But an average, should I say average, physiotherapist, when you do this, they'll probably think it's either spastic or the muscles are weak. You need to do more stretching, or think about. They will forget about the scapula
and the
altogether.
pelvis and all that. That's sometimes like the person is tilted this way. It's because from day one, when the person couldn't do anything, that's when you should have been moving the pelvis. Mobilizing it. Once you can get all the tilts of the pelvis working effectively, when the person starts walking, you don't have a problem. You get very good results with these basic stuff.
So my last question, I would want you to clarify any misconception you've heard about stroke, or any additional fact that you would want the general public to be informed about when it comes to stroke.
Okay. Briefly, I want to talk about the fact that stroke is a non-communicable disease, and as a non-communicable disease, we know per the current trend that the non-communicable diseases are really rising. Infectious diseases are there. For instance, in Ghana, the topmost is malaria when it comes to mortality. However, the non-communicable diseases are rising. Diabetes is rising, cancers and the chronic respiratory diseases, they are all rising. And the best way to prevent stroke or any of these non-communicable diseases, usually we focus on the primary prevention. So we look at, okay, you have to take your hypertensive medications, you have to do regular checkup, you have to do physical activity and all that. But there is another prevention. I don't want to go too much into it, but there's something called a primordial prevention, which is avoiding the risk factors. So if obesity is a risk factor, our young ones that are coming up, how can we avoid obesity? Because if you avoid obesity, then you are not at risk of getting the stroke. So those are things that we should do. So you are a young person, the person is just taking sweets, is taking all the oily stuff, and we normally does not engage this primordial prevention and control. So that's one thing that I am much interested in. So we look at the younger ones that are coming. How do we avoid these risk factors? So you have a child, the child is taking all these things we talk about. The child is always playing video game. That child doesn't have time for physical activity. I don't know if now they even do PE in the schools.
I mean, I think they do, don't they?
Yeah, but how seriously do we take it? All these things are important. These are policies that are put in place as a primordial prevention protocol. So these are things that as a nation we need to look at some of these things and try to reduce the incidence of these non-communicable diseases. Yeah, that's what I want to say. Yeah, thank you.
Thank you very, very much. We are really, really grateful that you were here today. It has been really educative, it has been insightful, it has been everything good. I mean, we've learned a lot, and we are very grateful that you took time out of that. I mean, I know how busy you can be, so for taking out time in your busy schedule to come here, to come and educate us, the public, therapists, clinicians, and every single person who would be interested in this topic, we are very, very grateful. God bless you. And we hope to see you soon for our Bobath workshop.
Thank you. Thank you for the opportunity.
For the sake of how close I know this man, I know how much he can charge. If he decides to pay him for what he has given to us today, I'm not sure he can pay. But then we have something small from Starbound that we'd like to use to show our appreciation to you for coming. I mean, it's not much, but we hope that you would like our presentation, and then you'd enjoy our range of products.
Sure.
All right.
As I said, I've used it before.
Okay.
And I enjoyed it.
All right. That is very good.
All right. Thank you.
Thank you very much for joining us on today's episode of the Physytek podcast. I hope you have been educated as much as I have been. Do not forget that today's episode was sponsored by Starbound. They have a wide variety of products that help in pain relief. They have the roll-on, they have the sprays and the gel. So I would recommend that you try any of these products for your pain relief. Also, do not forget to subscribe to our YouTube channel. We have more interesting episodes coming up. And follow us on all our social media platforms at Physytek. See you on our next episode. Bye.